Welcome to the Addiction Files. We are back, and this is in recognition of Alcohol Awareness Month, the month of April. We are discussing a topic of alcohol-associated liver disease. This is a fascinating topic and a good refresher for all of us. So, just starting off, let's talk about some of the definitions of alcohol-associated liver disease. So, what are some of the stages? What does this mean? So, let's look at this, Paula. The NIAAA, this is their definition, and then there's a couple more. So, we're going to kind of go through some of these consensus guidelines and definitions on what is alcohol-associated liver disease. So from the NIAAA, what this includes is a pathological spectrum of alcohol-related liver injury. And this comes from drinking beyond the US dietary guideline levels that can cause liver disease. And you get these progressive stages, and that includes steatosis, and we know that as the accumulation of fat in the liver, steatohepatitis, that is associated with inflammation, fibrosis and cirrhosis, that's the scarring stage, and then rarely hepatocellular carcinoma, and then the horrible and rare complication of alcohol-associated hepatitis. The stages of alcohol associated liver disease are not necessarily progressive, and multiple stages can be present in one individual with long-standing heavy drinking. So Paul, kind of expand on that a little bit. What are some of the other consensus guidelines? And when we talk about drinking beyond the US dietary guidelines and long-standing heavy drinking, what does that mean?
Sorry, what do you want me to
Sorry.
um
Well, I don't, do we want to go, because I know there was kind of some other definitions. Did you want to go into any of those? We don't have to, but I didn't know if you wanted to do some of those definitions, or we can just go into steatosis. I can edit that, and then you can start out with, I can just say, let's go into those more detail of what those definitions are.
yeah, I think so. Sorry, I wasn't prepared to answer that other question. And
Yeah, that's okay.
okay.
So let's go into more detail on each of those stages. So, Paula, do you want to start us out with what is steatosis?
Sure.
And
Yeah, okay. So like you said, Darlene, steatosis is otherwise known as fatty liver, and it's the earliest sign that the liver is injured. And this is actually present in a really large proportion of people who drink heavily. According to the NIAAA, 95 to 100% of people who drink heavily have steatosis. And what this looks like is fat accumulation in the hepatocytes, so in the liver cells themselves, which then increase in size. So they basically become these kind of globules, and they look like that on imaging. You can see these kind of fatty globules in the hepatocytes, and the liver becomes this fatty. It looks like this fatty has this fatty infiltrate. So steatosis, so fatty liver, is reversible if alcohol consumption stops for most people. And I always draw pictures for people. I'm sure you do too, Darlene, where
yeah,
you have a normal liver and then you have steatosis or fatty liver, and you have that like reversible sign in between the two. However, for about 10 to 35% of people with steatosis who continue to drink, well, they'll progress and they'll develop inflammation of the liver. So the liver will actually become inflamed and they'll get more advanced, serious stages of liver injury. And the next stage would be steatohepatitis, which you can talk about.
yeah. So steatohepatitis, you have fatty liver, and then you get this lobular inflammation, and you have now hepatocellular damage. This is considered chronic, and it is slowly progressive. And then you get this will you'll get 20 to 40% then will go to fibrosis, and then 8 to 20% will then progress to cirrhosis from this stage. So Paula, talk to us a little bit more about fibrosis and then cirrhosis, and I'm sorry, and cirrhosis from this stage.
Right. So, like we said, people don't necessarily go one from one to the other. They may have portions of the liver that are, just have some fatty infiltration and inflammation, and then parts that start to become more fibrotic. And this is when the liver begins to get collagen deposits that form in the liver, and that kind of looks like a chicken wire pattern. So it like infiltrates the liver, commonly around the hepatic vein, the terminal hepatic vein, and along the sinusoids. And it can really, because it's around the hepatic vein, it can impair hepatic architecture and blood flow. And then once we get to that stage, you get this kind of hardened down liver. So you get fibrosis first, where the liver gets this chicken wire pattern, and then you get scarring, and the liver really hardens down, and that's cirrhosis. And that's bad news. There's no coming back from cirrhosis. Even fibrosis is difficult to come back from. And once you have a cirrhotic liver, you have some very significant risks of complications, including portal hypertension, hepatic encephalopathy, which is a kind of confusion, and hepatorenal syndrome, where the liver is so affected and the blood flow through the liver is so affected that it then affects the kidneys. So if you have cirrhosis, the liver generally doesn't come back from that, and the only treatment of cirrhosis is a transplant.
Mhm.
So we don't want people's liver disease to progress to fibrosis or cirrhosis. I mean, even ideally, steatohepatitis should be a big red flag
Yes.
because, right? Yeah, because once you get inflammation, that's when you really run the risk of fibrosis and scarring. So once you know there's any steatosis, so fatty liver, you could really educate people, work on treating the alcohol use so that people can reverse back to a healthy liver. There's another complication that happens with people who have cirrhosis. About 2% of them are at risk annually for developing hepatocellular carcinoma, which is basically a primary liver cancer, so primary HCC. So those of us who take care of patients who have liver disease need to always be aware that we should be doing appropriate screening for hepatocellular carcinoma.
That's really important. So some of how common is this and how frequently are we seeing this? So there's certainly alcohol-associated liver disease is increasing. So the number of patients with alcohol liver disease on liver transplant lists has increased by 63% from 2007 to 2017.
That's
Did I say that
crazy.
right? Yeah.
63%.
And liver cirrhosis was at there was okay, sorry. It was estimated that there was 48,000 people with a diagnosis of liver cirrhosis in 2019, and this was a 47% increase from 2000. And interesting that this was more younger adults, women, and minorities. And tell us a little bit more about that. Who is at higher risk of these complications?
Yeah, well, just to note that alcohol related liver disease is now the number one reason for liver transplant in the
Yes,
country. And half of all of the deaths from cirrhosis are alcohol
all
related.
related. Mhm.
Yeah, which is crazy. So who's at risk? Well, you said we're seeing more young adults, women, and minorities. We're seeing the largest increase in alcohol use disorder and alcohol related liver disease. And what are the risks? Well, actually, being female carries a risk for liver disease, which I know you know this because we both treat a lot of women, but women don't know this. And I don't know if all women providers know this, but being female in and of itself is a risk factor for alcohol-associated liver disease. Heavy drinking is the number one risk. So amount and duration of alcohol use is the primary risk factor for developing alcohol liver disease. Also, the older you are, the more likely you are to develop this. If you have obesity, which makes sense, right? Because you have more insults to the liver in terms of underlying metabolic disease. If you smoke cigarettes, you're more at risk. And then if you have any other kinds of viral hepatitis, you're more at risk. So just kind of, again, the dual insult.
Yes.
There's some information about which kind of alcohol is more damaging to the liver. I thought this was interesting when we were doing our research. The bottom line is all alcohol is toxic to the liver. So when
Yeah.
you talk to people and they're like, oh, well, I only drink beer or I only drink wine, it's not really a true risk mitigation, although in terms of overall alcohol-related harms. However, when it comes to liver disease and alcohol, liquor is more damaging to the liver than beer and wine. However, just remember amount and duration of alcohol use, the primary risk factor. If women are drinking more than 2 drinks a day, more than 14 drinks a week, they are at very high risk for liver disease. And if you think about that, how much alcohol that is, that's not that much alcohol when you think
Yeah.
of populations who really drink quite a lot as part of their culture. And that's true for men too. If they drink more than 3 drinks a day and or more than 21 drinks a week, then they're at high risk of alcohol-related liver disease. The other thing that they've looked at is daily use versus binge use of alcohol. Which one of those increases the risk of advanced liver disease? Well, basically, it's both.
Yeah. That was
If you
interesting. And we'll go into that some more, but it's really interesting.
Exactly,
Yeah.
there's insufficient data. So a lot of this podcast, we've got the information from the American College, excuse me, the American College, the American Gastroenterology. You're gonna have to, oh my gosh, you're gonna have to edit this out. It is, let me get it right. American Journal of Gastroenterology clinical guidelines. So the ACG clinical guidelines on alcohol-associated liver disease, which was published in January of 2024. So just barely published in the American Journal of Gastroenterology, and the primary author is Joplin. And what they're saying is that insufficient data to determine whether binge drinking without daily heavy drinking predisposes to advanced forms of alcohol-related liver disease, but overall alcohol duration and amount do contribute. Why are women more at risk? We've talked about this. We actually have a whole podcast related to this. But do you want to review that for our listeners as to why women are more at risk?
Well, I mean, this is something that I think many of us already know. One, it's just related to total body weight. And so that's one thing for women. Then there is some theories with just hormonal effect. And so that's why women in general. So it's again not gender discrimination. This is just pure like physiology that why women are affected more. And then it's also just the like alcohol dehydrogenase enzyme also seems to have different effect and so has different level. So the alcohol dehydrogenase enzyme has a different level of activity as well. So that was another theory. And anything else I'm missing on that, Paula?
No, that's it. That's
Okay.
interesting.
So those are the three as far as just like when we see sex differences. Another really interesting just on the when going back to the binge and high intensity drinking, and this was really interesting in some of the journal articles that and this is again just some early studies, and so there's not a lot of data on that, but it's speculated that when you have higher blood alcohol levels, which it's easier, and this is why women, I think, are most, again, they have more consequences with binge drinking, but that's why smaller amounts of alcohol have more detrimental effects with women. But so binge drinking and what this new trend of high intensity drinking, they're talking about it promotes this bacterial translocation. This was a really interesting phenomenon, and this was actually new to me, hearing about this mechanism. And it also, that's what promotes liver fibrosis. That role, the exact role is still remaining to be established. So this is just an early area, but these are just some theories that still need to be fleshed out. But this is an area of research that I would recommend that we continue to follow because I think it's really fascinating. And but that kind of just explains that when you we need to be very, very careful about not screening for patients that just because they tell us they don't drink daily, we always just need to ask how much they're drinking total, because if a patient just if we just dismiss it because they tell us they don't drink daily, but they're binge drinking on the weekends, they can still be at risk. So we just need to be very careful and counsel our patients appropriately. Okay. And then how do we diagnose this, Paula? So how do people first how do we first come across somebody who maybe has alcohol associated liver disease, alcohol associated hepatitis? What do you typically see on the labs?
Well, there's several things you want to take into consideration when you have alcohol-associated liver disease on the differential, and the first one is history. So getting an accurate history from the patient in terms of what their alcohol use is, again, amount and duration, taking into um, account, do they binge drink? Do they daily drink? How long have they been drinking for? Have they had any periods of sobriety? The American okay, I've got to not say that, but the ACG clinical guidelines talks a lot about getting a good history and using scales like the audit scale to actually assess if people have an alcohol use disorder. And using your diagnostic tools and getting your history, you can use the DSM-5 to determine if someone actually has a use disorder or if they've got chronic kind of binge use. We commonly see alcohol liver disease manifesting in people's labs. So, we consider CMP, a CBC, GGT, maybe a CDT and the INR, like the standard basic labs that will give us an idea if people have some degree of alcohol-related
Hmm.
liver injury. CMP obviously showing us what their liver function tests are indicating, and not only AST, ALT, and bilirubin, but also what their albumin is. CBC labs are pertinent because they can tell us if there's any degree of platelet depletion, which can be a little bit tricky in chronic alcohol use because you can have bone marrow suppression in chronic alcohol use, which may make platelets low. However, if the liver is really damaged, people will start having low platelet function, and that's a significant indicator that you've got more advanced liver disease. Classically, we've used the GGT to see if people are drinking heavily, although the GGT is not very accurate and can be elevated for other conditions. So you do have to be cautious. And, I have to say, I don't use GGT very often. I don't know about you, but CDT, if we're going to use, instead of just trusting on an elevated gamma glutamyltransferase test, you can use a CDT, which gives us a little bit more specific
Yeah.
information about someone's drinking behavior for the past 30 days. But overall, laboratory tests are going to show AST greater than 50, an AST-ALT ratio of greater than 1.5. And typically, the AST and ALT are less than 400. If you have AST and ALT greater than 400, you may want to start looking for other causes of liver disease and other causes of liver disease. So remembering that sometimes people can have more than one
Yes.
etiology. And then again, remember to look for albumin, prealbumin, and platelets. One thing you want to do is we want to make sure that we don't just say, oh, this person's drinking heavily and they have these lab findings, therefore it's alcohol-associated liver disease. We want to make sure we actually rule out other common etiologies of chronic liver disease, especially chronic hepatitis infections, so viral hepatitis C and even B. So you want to make sure if you're working someone up, you want to do a viral hepatitis panel. You want to consider doing an autoimmune hepatitis panel and then checking for hereditary hemochromatosis and maybe Wilson's disease and can't talk today, sorry, abnormal alpha 1 antitrypsin labs. And I actually have a patient right now who has both hemochromatosis and alcohol liver related disease. And boy, that liver is not happy at all. So knowing that we have all those labs, there are risk calculators that you can use to determine disease severity and treatment options. They're particularly helpful when you have someone with alcoholic hepatitis or alcohol-related hepatitis. And I think you're going to talk about that in a minute, Darlene. But we used to use the child Pew score all the time. I think we've moved away a little bit from that. And now we use the Madre discriminant function risk, or the MDF, and we use the MELD score, or the MELD NA, the MELD with sodium score, especially for alcoholic hepatitis, just to let us know if we need to use, go down a certain treatment arm, like if we need to give steroids or if we need to push forward towards a liver transplant. In general, though, when you're trying to assess someone's true overall alcohol liver staging, you cannot do this with labs alone. You can get a pretty good idea if they have any fibrosis or cirrhosis by calculating a FIB-4 score, which is classically used for viral hepatitis, but it's actually helpful for alcohol-associated liver disease as well. And it's easy to calculate. So you can plug that in, get a FIB-4 score. That will give you an indication if you should be cautious. And then the standard of care is to perform transient hepatic elastography or a fibroscan to really see what the level of fibrosis is. And fibrosis directly correlates with long-term outcomes and survival. And it's great because it used to be, I mean, Darlene, when you and I did our training, and even up to 10 years ago, we would send our patients for liver biopsy
Everybody, yeah.
where they were. And now we're able to do these very non-invasive testing. And then, of course, physical exam is important. This is medical school stuff where there's classic physical exam findings for people with alcohol-related liver disease, certainly more end stage
Yeah.
liver disease where you have cirrhosis. You're going to have people who have ascites, possibly spider angiomata, asterixis, etc. And then you may or may not choose to do an EGD, not necessarily as part of diagnosis of the liver disease, but to look for complications to make sure you're not missing varices. And then, as we mentioned earlier, because 2% of people with cirrhotic livers have a risk of hepatocellular carcinoma, you must monitor for that with ultrasound. So that's kind of a long answer to your how do we diagnose it? We diagnose it with the history, physical exam, labs, biomarkers, imaging, physical exam, and then if we know that we have liver disease, we want to get an EGD and begin HCC or hepatocellular monitoring as well.
No, but I think those are really, really important. And it's common that you don't want to just go off of just liver enzymes alone. Frequently you'll have patients where someone told them their liver enzymes were elevated, and then they had another test and they had gone, up or down a little bit, and so they think that they're doing better and just continue drinking. So I think that was really good. That's why we need to always look at the big picture. So I think
Yeah.
that's really important.
And I think there's a huge role for us as clinicians to educate ourselves and educate our patients on liver
Yes.
disease. And I couldn't agree with you more. There's a real false, like, community and societal false sense of assurance when people have normal liver labs.
Yes.
Like, oh, my liver's fine. And actually, your liver labs can look completely normal when you have destroyed liver.
Complete cirrhosis, because there's
Exactly.
no there. And that's what I'm positive you do the same thing with your patients. We just tell them when it's no longer able, when it's completely scarred down and it's no longer to send out some warning signals and some helper signs out there, then you can get this false sense of security. Sorry.
Right,
There you go.
exactly. And I think because the liver is such a forgiving organ and it really does have the ability to heal and regenerate, and the treatment, I mean, I don't want to say simple because that's a bit insulting, because alcohol use disorder is one of the most difficult conditions to recover from, but the treatment is really straightforward, and it's abstinent. I mean, you're going to talk about it right now, but abstinence from alcohol, and it's nutritional, really. It's lifestyle. So people really can heal their livers, and they need to know what's going on. Like, I feel like I'm always harping on about people's livers because you only have one liver, and liver disease is so awful. Those of us who've seen people
Yeah.
with liver disease really feel passionately about this. So it's really important to educate people. And when you see signs of fatty liver, incidentally on like a abdominal CT, or you see early signs, with labs on for fatty liver to actually tell your patients, tell people and say, do you realize this could progress to inflammation of the liver, fibrosis, and even it can happen even if people stop drinking too, right? It can
Yeah.
still progress. So what about
Well,
treatment? What do we do?
well, let's talk about first a terrible
Oh,
complication.
let's
Let's
do.
talk about alcohol-associated hepatitis. And I think both you and I mean, we have trauma as residents. We have admitted patients with acute alcohol-associated hepatitis, and this is one of the worst complications that can occur. And it occurs young people. I've treated people in their 20s with this. And these people have even died from it, has a high mortality rate. And it's an awful, I mean, I can't stress important. So one, you need to be able to recognize it, and and the problem is the treatments for this are very limited. And then and then the next thing is we want to be able to prevent it. So recognizing it first, it can develop suddenly in about 20%. That's pretty high of people who drink heavily. It's a rapid onset, and it's of jaundice and of synthetic liver dysfunction and severe hepatic decompensation. Its prognosis is poor, like I said before. Mortality is anywhere from 20 to 40% at 3 months.
Oof.
And in people, and typically that comes for the mortality is high in people of the 70. It's about 70% of people who don't are the corticosteroid non-responders. That's a really, really poor prognosis, and it can occur in any stage. So this is not just people with cirrhosis or, um, steatohepatitis. This can occur anywhere along that progression. This is just associated with anyone who is heavy drinking. But we do need to be very aware 80% of people who develop this typically do have some level of cirrhosis. And it's like you said before, you will see different parts. Can have multiple stages. The symptoms that usually people will present with, it will be pretty severe abdominal pain, typically right upper quadrant, epigastric, decreased appetite or anorexia, encephalopathy, fatigue and fever, malaise, nausea, vomiting, neuropathy. And then this was a really interesting symptom that I had either learned and forgotten, but they have a sleep-wake cycle inversion. And you'll obviously see weight gain because typically you'll see
Mm.
some fluid retention because you've got that shut down, or you can also see some weight loss and some because of the anorexia. So that's typically the acute. And you already kind of went over the labs, but you will see a lot of severe, like you just see this terrible, it's kind of like this terrible, like a bone marrow toxin. Like you just see all of these abnormalities on their blood counts, their liver enzymes. It's like you said, if you see them, their liver enzymes are usually quite high, they're quite elevated in that stage. Treatment is corticosteroids. That's really the only treatment. And obviously, we can't stress this enough, it's cessation of alcohol. But if it carries in its supportive care, these patients are hospitalized, but we have both admitted patients with this, and it's absolutely awful, and it is a horrible way to die. And we've taken care of patients in the hospital with this awful, awful disease. So we can't stress the importance of that. So let's talk about just treatment in general. Anything else? Sorry, Paula, on that. Did I miss?
No,
Like I
no,
went through that pretty quick.
you
Okay.
got it.
And
Perfect.
then let's just go over treatment of alcohol-associated liver disease. So, do you want to start that? You put most of that because I feel like I've been talking a
Um,
lot. Do you want to go into that?
oh, okay. Well, the
Yeah.
one thing, I don't know if you want to put this, doesn't really matter, but
Yeah.
steroids versus no steroids, I guess, no, we don't need that was we could talk.
At 1 month survival, yeah,
Yeah.
do we want to do
Oh,
that?
it's so
I can
terrible.
do
No,
that.
I don't think it matters. It's all good. Okay. Let's
Yeah, I
see.
mean, I guess I could do, I mean, I did write
Yeah,
this down.
add that on because I think that's interesting because they use
Yeah.
Just
Because I
say
could
that
say,
the
so treatment
cortico.
particular was corticosteroids are currently the only available therapy for severe and providing survival at 1 month for 50 to 60% of patients. Med management is avoid obviously liver toxins, and then you would do obviously EGD for any varices, and then nutrition, low sugar, high antioxidants. And
Are
then
you
oh
for this, or are
that's
you
the
just
general.
previewing?
Yeah, that's the general. Sorry.
Oh no, that's
I was
okay.
going down. My notes were like everything. I put all of them into one.
Yeah, I
So
wrote this.
sorry.
I
Yeah.
just put this stuff all in, but
But it was mostly just avoiding like any other liver toxins and then ruling out any other concurrent diseases. Same thing at that time. I'll have to, maybe I just need to say that together so I don't run it down. Okay, so treatment for alcohol-associated hepatitis, corticosteroids are currently the only available therapy for severe alcoholic hepatitis, providing survival at 1 month for 50 to 60% of patients, besides our typical supportive care, avoiding any kind of other liver toxins. Okay, that's good. And then let's just talk about the treatment, Paula, for alcohol-associated liver disease. So what's our typical treatment besides obviously abstinence? We cannot stress the most of just like stopping alcohol, stop the insult to the liver. And then what other recommendations are out there?
well, that's the most effective strategy according to the American College of Gastroenterology is treatment of alcohol use disorder. So not only abstinence
Treat
of
the disorder.
alcohol, but actually I was really happy. I was really proud of the American College of Gastroenterology and their clinical guideline because they really drive home. They have pages of their clinical guideline discussing the treatment of alcohol use disorder as really the most important thing that you can do to prevent disease progression and to improve long-term outcomes of alcohol-associated liver disease. And what does that look like? Well, they really advocate for the use of medications for alcohol use disorder, and we'll talk about that in a minute. But otherwise, besides abstinence of alcohol and treating underlying metabolic disease, which can further insult the liver, as well as addressing any viral hepatitis, really, lifestyle approaches are very highly indicated and recommended, and they include nutritional recommendations of avoiding a high sugar diet. So sugar increases the likelihood of fatty liver, and that's why diabetics are more likely to have fatty liver disease. Diets that are high in antioxidants have been shown to be helpful for the liver. So has a daily dose of 2 cups of black coffee a day. So I know I tell my patients that, and they're either really happy about that news or they're not happy. But black coffee is very high in antioxidants, and it has a lot of specific, chemicals and phytonutrients that are very good at healing liver. And then we also want to address nutritional deficiencies for people who have liver disease. They're often malnourished and will suffer from thiamine,
Yeah.
B12, and zinc deficiencies, and very commonly have hypoalbuminemia. And so it's indicated to put people with advanced alcohol-associated liver disease on a high protein diet. And the goal is 1.2 to 1.5 grams protein per kilogram. And you can aim that per kilogram of ideal body weight. So I spend a lot of time also educating my patients on an anti-inflammatory diet that's high in good, safe sources of protein, and that's also avoiding sugar. So basically a whole food diet where you can just eat the rainbow. But let's talk about medications that we can use. And what's the skinny? I think as addiction medicine specialists, you and I get a lot of questions about what meds we can and can't use for people with alcohol liver disease. So thanks to this clinical guideline, we can really make it real clear what the evidence is when it comes to the FDA approved medications and then some of the off-label medications. Darlene.
Well, I mean, I think let's just start. I'm going to kind of start from the bottom of what you should not use when you have alcohol associated liver disease. Now, this is only when you have alcohol known is disulfiram. You would want to avoid along that spread. So this is a conditional this is conditional with low evidence. But if you've got known alcohol associated liver disease, then avoid disulfiram is what is in in the ACG recommendations. In patients with compensated, and that's many of our patients that you see, particularly on an outpatient basis, both the short and long acting forms of naltrexone can be used. And even with compensated, but if you have early alcohol associated liver disease, you can still use that. But if you have compensated cirrhosis, you then need to avoid naltrexone
I think
and be
that's, sorry, I think
cautious.
that's opposite. So it's
Okay,
early alcohol liver disease and compensated
compensated
cirrhosis is
cirrhosis.
okay, but
Okay,
not decompensated cirrhosis.
is this, yeah, I don't know why it's saying it may be, okay, let me say that again. Yeah, both short and long term acting, yeah. So naltrexone, both short and long acting forms can be used in early alcohol liver disease and those with compensated cirrhosis, but they should be avoided if you have decompensated cirrhosis or liver failure. And then just be cautious with kidney disease with naltrexone. But in general, again, for most of the patients that we're seeing in the outpatient setting, you can use naltrexone, and that has been very effective. In compensated alcoholic liver disease, you can use gabapentin or topiramate along with their, and this was interesting because we've talked about this in past. There's not a there's moderate level of evidence of baclofen as well with compensated alcoholic liver disease. So
Yeah,
there's your
they recommend baclofen is like the number one, has the strongest evidence out of the all of these medications, and they did studies over a period of
yeah
9 months, starting with 5 milligrams TID and increasing it every 3 to 5 days to a dose of 15 milligrams TID. And it's interesting because I remember the clinical guideline for the management of alcohol-related liver disease came out quite a long time ago,
yeah
relatively, and now this is re-updated. And we don't really use baclofen very much for the treatment of alcohol use disorder, except for this recommendation that comes out again that was specifically for people with compensated cirrhosis. The data is supportive. So I don't know, take it or leave it. It's a strong recommendation from this society. It's pretty fascinating. Why it
yeah
would just be unique to that population and have some efficacy is kind of curious.
yeah it is
But otherwise, bottom line is you can use acamprosate, naltrexone, gabapentin, topiramate, and as long as you don't have decompensated cirrhosis, if you can use naltrexone injectable as well, but you should just avoid disulfiram with anyone with liver disease, honestly.
yeah
Disulfiram causes hepatotoxicity, and you don't want to get messed up in that, and you don't want to cause someone more insult.
yeah
So disulfiram is the one that you do not want to use.
yeah
So if you are out of options for people who have advanced liver disease and they're fibrotic, cirrhotic, or have alcohol-related hepatitis, and their MALD score is greater than 20, or their MADRE, I think their MDF has to be greater than like 35, and a bunch of other conditions are present, then liver transplant is indicated. And for those of you who work in this field, I really recommend you read the ACG clinical guideline on liver transplant because, as we all know, there's been a required 6-month sobriety period before people can be eligible for liver transplants, but they're now doing a lot of studies on early transplant and how people do in terms of the transplant itself, but then what the return to drinking is with early liver transplant versus traditional liver transplant, which is following a 6-month period of sobriety. And, either way, there's about a 30% post-drinking rate, post-liver transplant drinking rate, where people will experience a slip or they'll return to sustained alcohol use within 2 years. So 30%, I mean, considering how severe alcohol use disorder is, I don't know if that's good or bad, but we need to be better at treating alcohol use disorder to help people have the best odds.
hmm
And the bottom line with early versus traditional, liver transplant is that they were almost the same. They almost had the same return to drinking rate. The difference is actually lies for both groups in some other risk factors. So whether or not you've had a period of 6 months of sobriety or not depends on, you're much more likely to return to drinking if you have certain risk factors, which I'm trying to remember them now, but they were, if you have a history of criminal behavior around drinking, so DUIs, if you've been in and out of residential or rehabilitative treatment and failed. So in other words, you've had multiple attempts at stopping drinking before. And then the older you are, you're more likely to return to drinking. So I think that's really interesting. And you and I have both sat in this situation where we're very frustrated waiting for someone to get a transplant, and there's a certain percentage of people who will actually return to drinking while they're waiting for a transplant, which is just devastating. So it's a fascinating
Yes.
article. You put in some other resources for this episode, which I'm sure you'll put on the show notes, but there's a very good article in the American Family Physician Journal from 2022 called, oh, it's specifically on alcoholic hepatitis diagnosis and management. So there's some good resources out there, Darlene.
Yeah, there's some great resources. And I think, the take home message is there's all of these medications for treatment for all of the stages of where they are in this alcohol liver disease. And so don't stop treating the patient. And it's like I said, I really think this is fascinating where they're looking at early transplant. So I think stay with your patient and keep treating them. And I think that's where sometimes we kind of get nervous and hold off because we kind of get it in our heads, oh, I can't give them these medications. And I have had patients come to me that sometimes they stop some of their medications, but I really like that they have these guidelines. Keep using these medications and do whatever we can to help them. We got to keep helping them get to their goal. Okay.
I love that.
That's a great episode. Thank you so much,
Thank
Paula.
you.
Have a great night. Let's
Sorry, I don't know what's wrong with my brain. I think